Good day, dear great surgeons. Today we're gonna talk about pediatrics. Pediatrics is very important chapter in every MRCS exam, and you have to master it pretty well because it's overlapping with many chapters like trauma, preoperative, postoperative, and the major part in GIT and orthopedics. Every exam will have a question for trauma and orthopedics as well as GIT for pediatrics. So it's a major chapter in MRCS. So let's have a ride through our voice notes and make it just like a piece of cake as usual and crack it together. Let's it go on.
Algal syndrome is autosomal dominant disorder characterized by presence of paucity of bile duct and cardiac defect. Only the embryonic form of the biliary atresia is associated with cardiac and immunological defect. That's why Algal syndrome might be confused to somehow with the biliary atresia. A midline cystic mass of an infant of 3 days age group, most likely to be bronchogenic cyst. It will be radio-opaque shadow with airflow level in the chest X-ray. The most common type of hernias, all hernias, is the indirect inguinal hernia. And in children and pediatrics, indirect inguinal hernia is the rule. It's due to persistent processus vaginalis. The direct hernia is a weakness in the posterior wall. There is no processus vaginalis in the direct hernia. That's why in pediatrics more common to have indirect inguinal hernia, not direct. The only swelling in the neck transilluminate is the cystic hygroma, and in the scrotum will be hydrocele. We don't do hernioplasty in pediatrics because the internal ling and the external ling in pediatric are opposing each other, and anatomically you know that they are apart. They form a canal by being apart from each other. But in pediatric, when the children are born, you will find the internal ring and the external ring if they are behind each other. There is no separation. But after puberty, the internal ring and the external ring have an interval. That's why there is no hernioplasty is done in pediatrics. We do only herniotomy, and hernioplasty is done after puberty, after full maturation of the abdominal wall. Please think of necrotizing enterocrisis in every premature patient mentioned in the MRCS exam. Prematurity is the main risk factor for necrotizing enterocolitis, and early features will include abdominal distension, passage of bloody stool, and X-ray may show nematosis intestinale, the air in the intestine, and evidence of free air. Increased risk with empirical antibiotics are given to infant beyond 5 days. Treatment is with total gut rest and total parenteral nutrition. Babies with perforation will require laparotomy. Take care, duodenal atresia is 1 in 5,000 and it has a higher rate in Down syndrome. So when he is stating in the question that the child has a prominent epicanthus fold of the eye and single palmar crease, think of the trisomy 21 and Down syndrome. That will raise the probability of congenital malformations like duodenal atresia. It will present few hours after birth, and in radiology you will find double bubble sign. A contrast study may confirm, and the treatment will require duodenostomy. Remember that in duodenal atresia, it's in the very first hours of the pediatric life, in the infant life, after his very first feeding or 2 feeding, he will not tolerate any feeding and will go for vomiting, which is biliary stained. Yes, bile stained. Remember that cystic hygroma is a congenital lymphatic lesion, lymphangioma, typically found in the neck and classically on the left side. Most evident at birth, around 90% before 2 years of age, and it will have a trans-elimination test positive. It's the only neck tumor that trans-eliminate. And of course, the cystic hygroma mostly in the posterior triangle. Brachial cyst. Remember, brachial cyst is an oval mobile cystic mass that develops between the sternocleidomastoid and the pharynx. It developed due to failure of obliteration of the second branchial cleft in embryonic development and usually present in early adulthood. Thyroglosal cyst is a very common neck swelling and have to be differentiated from the thyroid because the thyroid enlargement and the goiter move up and down with deglutition but doesn't move with protrusion of the tongue, unlike the thyroglossal cyst. And the thyroglossal cyst move up and down with the deglutition and protrusion of the tongue because it occurs at any pass of the thyroglossal duct from the base of the tongue to the suprasternal notch. Because embryologically the thyroglossal tract arises from the foramen cecum at the junction of the anterior 2/3 and posterior 1/3 of the tongue, that's why it have a relation with the tongue protrusion. And yes, as all of you know, the thyroglossal cyst is removed with cyst trunk operation. You have to take the whole tract, otherwise it will cause a thyroglossal fistula. So please, during cyst trunk operation, you have to take the whole tract up to the hyoid bone breakage. Remember, in intussusception, we have two types mainly, the ileoileal and the ileocolic. Ileoileal intussusception, where the ileum invaginates into another ileum, are far less common than the ileocolic variant, where the ileum invaginates the colic. So, in ileoileal intussusception, this will require surgery. No pneumatic compression or no air insufflation can do anything in ileoileal intussusception, and this will require urgent surgery to do laparotomy, and you have to take those ileum from ileum apart. So in paraumbilical hernia, you will find a crescent shadow around the umbilicus, but in the umbilical hernia is a congenital defect in the umbilicus which didn't close congenitally after 2 years, which will require surgical interventions, and there is no crescent in the umbilicus. And by the way, if the baby born with a defect in the umbilicus more than 2 centimeters, you will not wait until above 2 years old. More than 2 centimeters, you have to do it surgically as long as the patient is fit. Pyloric atresia is form of obstructive jaundice in children, congenital obstructive jaundice, where the baby will be jaundiced for more than 14 days. The pale stool will be a very feature characteristic and associated with cardiac malformation, polysplenia, and situs inversus. We stated that biliary atresia is a form of obstructive jaundice to think of that the jaundice is caused due to conjugated bilirubin, because when you run your test and exclude that this is not a physiological jaundice, you will differentiate between the obstructive jaundice and the physiological jaundice by the type of the bilirubin causing this jaundice. If the unconjugated bilirubin, so it's mostly physiological jaundice or other anomaly, but if it's conjugated bilirubin, it's more likely to be a very serious problem, and biliary atresia must be in your differential. Early recognition is important to prevent liver transplantation, and nutrition support is very important. Kasai operation, which is Roux-en-Y portojejunostomy, where we open the liver ports to drain into the jejunum, is to prevent the liver congestion and liver death, which will require liver transplant. if we didn't early do the procedure. To investigate a jaundiced baby, go for bilirubin, total and direct. If the direct is a cause, go for thinking about biliary atresia and other causes. Go for ultrasound of the liver. Go for hide the scan. There would be good uptake but no excretion in biliary atresia. In intestinal malrotation with volvulus, usually caused by incomplete rotation during embryogenesis, and the presentation age usually the first week of life after birth. Volvulus with compromised circulation may result in peritoneal signs and hemodynamic instability. Diagnosed by upper GI contrast study may show DG flexure more medially placed, and ultrasound will show abnormal orientation of the superior mesenteric artery and superior mesenteric vein, and the treatment might require LADS operation. Review together some names of famous operations like the Kasai operation for biliary atresia and duodenectomy for duodenal atresia, while the Ramstad procedure for congenital hypertrophic pyloric stenosis (SHIPS), while the Hilar cardiomyotomy for atresia of the cardia, and the Swenson operation for Hirschsprung. Remember, Duhamel and Swavey and Hirschsprung and Swenson, Duhamel, Swavey for Hirschsprung. The Nissen-Fandor implication for the hiatus hernia, while the Whipple procedure for cancer pancreas, the LADS procedure for malrotation, and the interception managed by pneumatic reduction for ileocecal interception and laparotomy for ileoileal interception. You are doing great. So again, necrotizing enterocolitis is more common in premature infant. Mesenteric ischemia causes bacterial invasion of the mucosa leading to sepsis. Terminal ileum, cecum, and the distal colon are commonly affected. Again, terminal ileum, cecum, and distal colon are commonly affected. The abdomen will be distended and tense, and the infant passes blood and mucus per rectum. The X-ray will show distended lobe and pneumatosis intestinal, and gas bubble may be seen in the bowel wall. So, meconium ileus is usually delayed of passage of meconium and abdominal distension. The majority of the cases will have cystic fibrosis, and it tested by sweat test. Yes, chloride sweat test. The chloride sweat test is very important recall question. And by the way, the X-ray may not show a fluid level as a meconium because the meconium is viscid, and PR contrast study may dislodge the meconium plug and be therapeutic as well. So meconium ileus may be therapeutically managed by, yes, PR contrast enema. The infant who don't respond the PR contrast enema and nasogastric N-acetylcysteine will require surgery to remove the plug, unfortunately. So again, meconium ileus, cystic fibrosis, sweat chloride test, N-acetylcysteine, if not responding to the PR contrast material, will require surgery to remove the plug. In congenital diaphragmatic hernia, we have two types, Morgagni and Bogdaric. The Bogdaric is almost always in the left side posterolaterally, and it's more common and will cause more manifestation, and the lung will be hypoplastic and appear early, while the Morgagni may pass silently with no manifestations at all, and it will be less common and on the right side. So if a baby is manifesting with diaphragmatic hernia and breathing compromisation, and you find the intestine in the chest wall, it's more probably to hear the intestinal sound as well with auscultation. So this patient is mostly a Bogdaric type. Medicine is incidence. It's all about incidence. Pyloric stenosis typically present in the 2nd to 4th week of life, with vomiting, although rarely may present later up to 4 months, It's caused by hypertrophy of the circular muscle of the pylorus. That's why it's called congenital hypertrophic pyloric stenosis. Congenital hypertrophic pyloric stenosis. It's due to hypertrophy of the circular muscle of the pylorus. Its incidence 4 to 1,000 live births, 4 times more common in the male. Poor male. We are very poor. We have many diseases. 10 to 15% of the infant have positive family history. The firstborn are more commonly to be affected. So if you are the firstborn, you're more common to be affected or have affected with it. The features of pyloric stenosis will be projectile vomiting, typically 30 minutes after feeding. The baby will eat from here and vomit from there. Constipation and dehydration may also be present because the patient will be malnourished. Palpable mass is a key. Take care. Palpable mass may be present in the upper abdomen, and this is a key. The hypokalemic alkalosis due to persistent vomiting is another key. In the exam, he might present to you an ABG asking you about what is this case. You will find hypokalemic alkalosis. Diagnosis most commonly made by ultrasound or test feed. Management with Ramstadt pyloromyotomy. By the way, stenosis means narrowing. If in case you are not understanding what stenosis means, stenosis means narrowing. Remember, congenital hypertrophic pyloric stenosis, the vomiting will not be bilious stent because nothing passes from the duodenum to the stomach. The stomach can't pass anything from the stomach to the duodenum. So would the duodenum be able to pass the bile to the stomach to be vomited? Take care. Congenital hypertrophic pyloric stenosis, there is no bile in the vomit. He vomited his own food. He didn't digest it either. After 30 minutes, he will not tolerate this food. Take care. Regarding infantile hypertrophic congenital hypertrophic pyloric stenosis, take care. It's almost always hypokalemic metabolic alkalosis, but it comes with paradoxical aciduria, secondary respiratory acidosis. Why is that? Take care. The projectile vomiting with the congenital hypertrophic pyloric stenosis leads to loss of fluids and potassium and HCl. This will lead to dehydration and hypokalemia. Loss of potassium, hypokalemia, loss of fluids, dehydration. This will lead to loss of the acid, causing increase of the alkali, metabolic alkalosis. So, renal compensation will lead to loss of the bicarb. The sodium bicarb will be lost. This will lead to secondary hyperaldosteronism, and this will retain the sodium and excrete the HCO3 as well as the bicarb, leading to an acid in the urine. It's renal compensation. This will lead to hypokalemic metabolic alkalosis with paradoxical aciduria. It's renal compensation. Exomphalus and diaphragmatic hernia are commonly associated with intestinal malrotation. And remember, the intestinal malrotation is treated by Ladd's procedure. A child less than 2-year-old with sausage-shaped mass most probably will ileocolic intussusception until proven otherwise, especially if he stated as well vomiting and diarrhea with red currant jelly stool. Retractile testes. This is a good congenital condition where the patient has his own testicle, thank God. They just appear and disappear. The testicles appear in warm condition and disappear in the cold condition. Or you can make him squat to make sure that he has both testicles. This will relieve with age, doesn't need any intervention. Esophageal atresia. It's associated with tracheoesophageal fistula and polyhydramnios and may present with shocking and cyanosis spell following aspiration and have many bacterial association anomalies. Bacterial syndrome or bacterial association combination. In the children, when you find any congenital anomaly, you have to search for the bacterial. vertebral anomaly, anal atresia, cardiovascular anomaly, tracheoesophageal fistula, esophageal atresia, renal or radial anomaly, and limb defect. Vacteral. The very first letter in each anomaly combined make the word vacteral. When you find a child with any anomaly, search for the others. Tetralogy of Fallot. Tetralogy of Fallot is the most common cause of cyanotic congenital heart disease. It's typically present at around 1 to 2 months, although may not begin until the baby is 6 months old, but it has 4 characteristic features. That's why it's a tetralogy of Fallot. The 4 characteristic features are ventricular septal defect, VSD, right ventricular hypertrophy, right ventricular outflow tract obstruction and pulmonary stenosis, and overriding aorta. Again, VSD, right ventricular hypertrophy, right ventricular outflow tract obstruction and pulmonary stenosis, and overriding aorta. Of course, right to left shunt is characteristic feature of Fallot tetralogy. Remember that tetralogy of Fallot is surgically repaired, which is undertaken in 2 parts, and the cyanotic episodes may be helped by beta blocker or reduce the infundibular spasm. However, at birth, transposition of great arteries is more common lesion, as patients with tetralogy of Fallot generally present around 1 to 2 months. Posterior urethral valve are one of the commonest causes of poor urinary stream and hesitancy in children. There is no children have prostatic disorder. It's very rare. If any baby didn't pass stool for 24 hours, this is considered as delayed passage of meconium, and this is suggestive of Hirschsprung disease, and the investigation of choice is full thickness rectal biopsy. Hirschsprung disease is confirmed via the full thickness rectal biopsy. A correct treatment will be laparotomy and stoma formation, and at the age between 9 to 12 months of age, definitive surgery will be done. Usually, resection and primary anastomosis is performed, the Swenson operation. Hydrocele in adult is via scrotal incision. Hydrocele in pediatrics is via inguinal incision. Even if intussusception with ileoileal is a must surgery and ileocecal, we go for pneumatic reduction first. If the patient or the baby have localizing peritoneal signs, go for laparotomy whatever the type of intussusception is, even if ileocecal. But if the baby with intussusception, especially if ileocecal, which is the most common type, without any localizing sign, attempt a pneumatic reduction under fluoroscopic guidance, and this will usually do the trick. Remember, esophageal atresia have high incidence with polyhydramnios, and the distal tracheoesophageal fistula is the commonest variant, and of course it will have high incidence with imperforate anus and have absence gastric fluid in the antenatal ultrasound. This is a combination of vacteral. Remember that paraphimosis is a urological emergency in which the retracted foreskin of the penis of an circumcised male can be returned to its normal anatomical position, and it's important for clinicians to recognize it because it's emergency. It might cause the gangrene and amputation of the glans penis, and somehow it's important. So here, circumcision will be a must in paraphimosis. Regarding the male genitalia, there are some specific definitions. You have to differentiate between them: phimosis, paraphimosis, balanitis, and hypothesis and meatitis. Regarding the phimosis, it's the stenosis of the prepetual ring with an inability to retract the foreskin. This will make the male susceptible to infection and can't urinate normally, while the paraphimosis is the retention of the retracted skin. Again, Paraphimosis is the retention of the retracted foreskin in a position proximal to the coronal sulcus. This might cause gangrene of the glans penis. And by the way, the glans penis is important for some extent, right? The balanitis is inflammation of the foreskin. The pothitis is inflammation of glands. The meatitis, inflammation of the urethral meatus. Again, paraphimosis is a surgical emergency. If not reducted the foreskin early, it will cause gangrene. That's why here circumcision in paraphimosis might be emergency, not just religious beliefs. Remember that cystic fibrosis is the most common cause of meconium plugs, and the most common test for cystic fibrosis will be, yes, sweat chloride test. Meconium ileus, again, sweat chloride test. Cystic fibrosis, acetylcysteine is the drug may be used. If not, you will require surgery. X-ray may not show fluid level as meconium is viscid, by the way. Care in meconium ileus, BR contrast study is not only diagnostic, it might be therapeutic. It has to be used before any attempt of any surgery. Diverticulum is the number one cause of painless massive GIT bleeding, which requires transfusion in children between the age of 1 to 2 years. Michel Diverticulum is congenital abnormality that results in incomplete obliteration of the vitello-intestinal duct, and normally in the fetus there is attachment between the vitello-intestinal duct and the yolk sac. This disappears normally at 6 weeks of gestation. The tip is free in majority of the cases and associated with enterocytoma, umbilical sinus, and omphaloileal fistula. Take care. Arterial supply will be omphalomesenteric artery. And Michel Diverticulum is very famous of the rule of 2. 2% of the population, 2 inch long, 2 feet from ileocecal valve. Again, 2% of the population, 2 inch long and 2 feet from the ileocecal valve. Typically lined by ileal mucosa, but ectopic gastric mucosa can occur. Take care again. Ectopic gastric mucosa can occur in Michel Diverticulum with the risk of peptic ulceration. Pancreatic and jejunal mucosa can also be found in Michel Diverticulum, and there is a record about this question specifically. Take care. Intraoperative, when you are performing appendectomy. For example, if you found the appendix normal, you have to search for the Michel. And if you are in female, not just Michel, search for the female organs like the ovaries and the fallopian tube. Think for them. Necrotizing enterocrisis, most of the cases will settle with conservative management with nasogastric decompression and appropriate support, while laparotomy should be saved if the patient is deteriorating. Transilluminated swelling in the scrotum is hydrocele, and hydrocele in congenital or pediatrics done via ligation of the patent processus vaginalis via inguinal approach. There is no indication for scrotal surgery for hydrocele in young children. Take care, physiological jaundice will last only for 14 days, so any baby full term after 14 days of jaundice, you have to be cautious and search for the reasons, and a conjugated bilirubin check will be a must to rule out biliary atresia. Biliary atresia is very dangerous. It might require, yes, liver transplantation. And this, no one can live without a liver. Take care, physiological jaundice in full-term baby will only last for 14 days, and in preterm infant it will be only for 21 days. After 21 days in preterm infant or more than 14 days in full-term infant, think of, yes, biliary atresia and other pathological cause of jaundice. There is no physiological jaundice lasting for 14 days in full term or 21 days in preterm. Persistent vitello-intestinal duct may allow the persistent and ongoing discharge of small bowel content from the umbilicus. And this fluid may be very irritant to the surrounding skin, by the way. Here, persistent Eurekas, characterized by urinary discharge from the umbilicus. It's caused by persistent Eurekas, which attach to the bladder. They are associated with urogenital abnormalities as well. Persistent Eurekas is something, and persistent vitello-intestinal duct is another entity. Take care. Infection of the umbilicus is the omphalitis. So omphalitis is a condition which are causing umbilical skin infection. Remember, the balanitis is the infection of, the foreskin of the glans penis. A very common condition in children is the umbilical granuloma. It consists of cherry red lesion surrounding the umbilicus. It may bleed on touch and may be seropurulent discharge. The infection is usually responding, and if not responding well, you can use chemical cautery with topical applied silver nitrate. We have stressed many times upon the umbilical hernia. It's found in 20% of the neonates will have umbilical hernia, and it's more common in premature infant. The majority of these hernia will close spontaneously within 2 years. No intervention done for the umbilical hernia before 3 years, unless the hernia defect more than 2 cm, because strangulation is very rare. However, the para-umbilical hernia, in contrast, more likely to have surgery because they are less likely to resolve spontaneously. And the para-umbilical hernia is differentiated from the umbilical hernia by the crescent sign. A young boy without localized pain, with weight loss, bloody diarrhea, by abdominal examination is unremarkable. The most probable diagnosis you have to be thinking of is inflammatory bowel disease. The systemic features here is strongly suggestive inflammatory bowel disease rather than any other cause, because colorectal cancer in a young patient is unlikely at this age. Hirschsprung disease is more common in us, the poor males. It may present with delayed passage of meconium. The mucosal biopsies are inadequate for diagnosis alone. There is a transition zone from the contracted aganglionic segment, again the contracted aganglionic segment, this is the abnormal area by the way, to dilated normal bowel. So the dilated normal bowel, the dilated is normal, the contracted is the aganglionic abnormal, Omparium enema. Take care, high fever and mild abdominal sign in younger children should raise a suspicion for mesenteric adenitis. And by the way, a perfect ultrasonographist will take this sign and get it for you. Mesenteric adenitis may mimic appendicitis, but appendicitis is likely to produce more localizing sign and seldom present with high fever. Appendicitis more probably to be anorexia and localizing pain. There is no appendicitis without anorexia. When the parents are relative and the child coming with right iliac fossa pain, you can put the FMF in your differentials. But of course, what's common is common. Appendicitis is the first localizing pain in the abdomen, especially in the right iliac fossa. But keep it in mind, familial Mediterranean fever. Remember, neonates should receive glucose 10% during surgeries, while the other children should receive isotonic crystalloid. Remember the maintenance fluid for the children. For the first 10 kg of the body weight, give 100 ml per kg per day. For the second 10 kg body weight, give 50 ml per kg per day. And above 20 kg, give 20 ml for each kilo per day. Take care. Bilious vomiting in neonates is a surgical emergency, and it's intestinal malrotation and volvulus until proven otherwise. Again, bilious vomiting in neonates is a surgical emergency, and intestinal malrotation and volvulus until proven otherwise. Take care. A 1-year-old human being. You can't think of appendicitis. Appendicitis doesn't come in the extreme of ages. Neither the very old or the very young. In the very old, think of cancer. In the very young, think of other differentials. The commonest emergency of this age group at 1 year old is inguinal hernia, followed by intussusception. Eurekas will present with umbilical urinary discharge. The skin may become macerated if not properly cared for, and the discharge is most likely to be present when intra-abdominal pressure is raised. It's associated with posterior urethral valve. There is a surgical wisdom. Never trouble the trouble until the trouble troubles you. The best surgeon knows when to not operate. Again, the best surgeon knows when not to operate. Surprise! A 4-year-old baby can get a rectal anal fissure. Yes, painful rectal bleeding in the age group of 4 is typical due to fissure. Treatment should include stool softening and lifestyle advice. They mostly get anal fissure at this age due to dehydration. Take care. There are 2 main types for congenital heart disease: cyanotic heart disease and acyanotic heart disease. Acyanotic means non-cyanotic heart disease. Cyanotic heart disease, transposition of great arteries are most common at birth, followed most common overall. So, TGA most common at birth, but followed is most common overall, those for cyanotic heart disease, while the acyanotic VSD most common cause for acyanotic heart disease. Regarding the acyanotic heart disease, the VSD is most common cause of acyanotic heart disease, and VSD are more common than ASD, by the way. However, in adult patients, the ASD are more common new diagnosis as they generally present later. Isn't it amazing that Tetralogy of Fallot is a cause of cyanotic heart disease, but it have VSD, which is non-cyanotic heart disease? So Tetralogy of Fallot is tetra for congenital anomalies, where we have overriding aorta, pulmonary stenosis, and VSD with right ventricular hypertrophy. The most common cyanotic heart disease, which is Fallot, has in its criteria the most common non-cyanotic heart anomaly, which is VSD. Remember always, TGA is the most common cyanotic heart disease at birth. Take care. There are 2 terms, gastrocases and exomphalus. They are related to abdominal wall defect in children and the neonate. Gastrocases is isolated abnormality, where the bowel lies outside the abdominal wall without any covering, through a defect located to the right of the umbilicus. While the exomphalus, any organ like the liver or the gut, remain covered with the membrane sac connected to the umbilical cord, and it's associated with other developmental defects. So gastrocases has no covering over the viscera, unlike the exomphalus, which have even a membranous sac covering. It's very important and very challenging. Gastrocases have high mortality rate. Even necrotizing enterocolitis often has a delayed presentation, and affected infant will typically pass bloody stool. Plain film will show pneumatosis intestinale, air in the intestinal wall. However, the prematurity of the infant is a key in your exam. Remember, biliary atresia is usually present with obstructive jaundice, where the conjugated bilirubin is high, more than 14 days in full term and more than 21 days in preterm. A Kasai procedure is best performed in the first 8 weeks of life. If Kasai procedure is successful, most patients will not require liver transplantation. Again, Kasai procedure best performed in the first 8 weeks of life. If Kasai procedure is successful, they will not require liver transplantation. 45% of the patient post-Kasai procedure will require transplantation, unfortunately. However, overall survival following a successful Kasai is 80%. Omphalitis is infection of the umbilicus, mostly with Staph aureus. The condition is potentially serious. Why is that? Because infection may spread rapidly through the umbilical vessel in neonate, with a risk of the portal pyemia and portal vein thrombosis. Treatment is usually with combination of topical and systemic antibiotic. Take care, it's high risk of portal pyemia and portal vein thrombosis. You will understand why this is a risk if you understand the embryological cardiac cycle. The fetal circulation key. The oxygenated blood comes from the placenta traveling to the fetus in the umbilical vein. The umbilical vein dumps 50% of the blood into the inferior vena cava through the ductus venosus, and the other 50% of the blood enters the inferior margin of the liver. The blood from the inferior vena cava enters the right atrium. Since the placenta is supplying oxygen to the fetus, much of blood is shunted away from the lung through the foramen ovale and the ductus arteriosum. Blood travels from the left ventricle to the aorta, which gives the blood to perfuse to the organ. Blood then enters very low resistant umbilical artery on its way back to the placenta. To make it simple, the fetal circulation again from the placenta to the umbilical vein to the ductus venosus, inferior vena cava, to the right atrium, to the foramen ovale and pulmonary trunk, to the ductus arteriosus, to the aorta, systemic circulation, umbilical arteries again, to end in the placenta. To make it simple again, placenta, umbilical vein, ductus venosus, foramen ovale, ductus arteriosus, umbilical artery, and the placenta. It starts with the veins, ending with the arteries. Unlike our circulation, we are fed with the arteries and drained through the veins. In children, they are fed through the veins and ending and draining to the arteries. Starting with the umbilical vein to the ductus venosus, through the foramen ovale, to the ductus arteriosus, again to umbilical artery and the placenta. To be more precise, in the fetal circulation, we more likely to say the ductus arteriosus sends the oxygen poor blood, not deoxygenated blood. Oxygen poor blood, not deoxygenated blood, sends it back to the placenta. Pyloric atresia usually present with obstructive jaundice, and Kasai procedure is best performed in the first 8 weeks of life. And if Kasai procedure is successful, most patients will not require liver transplantation, thank God. And 45% of the patients post-Kasai will require transplantation, unfortunately. However, overall survival following the procedure is 80%. Take care, cleft lip and palate are the most common congenital deformity affecting the orofacial structure. While they may be an isolated development malformation, they are also recognized component of more than 200 birth defects. The incidence is high, 1 to every 600 pairs, so it's very common. The commonest variant are the combined cleft lip and palate. It's 45% of the patient will be combined cleft lip and palate, while isolated cleft is the least with 15% only, and isolated cleft palate about 40%. So the highest incidence is for the combined cleft lip and palate, then the isolated cleft palate, then the least will be cleft lip. The etiology again of the cleft lip occur as a result of disruption of the muscles of the upper lip and the nasolabial region. So it's not the problem of skin only, it's the technicality is to repair the muscle and make it contour with the labial fold. So again, the problem will be due to Muscle compromise chain of muscle via the nasolabial fold. So, incomplete fusion of the nasolabial muscle ring is the problem in the cleft lip, while in the cleft palate, the primary palate consists of anatomical structure anterior to the incisive foramen. The secondary palate lies more posteriorly and subdivided into the hard and soft palate. So we are talking about the cleft palate, not only a word called cleft palate. No, we have the soft palate and the hard palate. It might involve the hard palate or even the soft palate or both. The cleft palate occur as a result of non-fusion of the two palatine shelves. So the cleft lip due to the nasolabial ring, while the cleft palate due to, yes, the palatine shelf. Both hard and soft palatine may be involved. Complete cases are associated with complete separation of the nasal septum and vomer from the palatine process. Here, unilateral isolated cleft lip represents the failure of the nasolabial ring fusion. It has no relation to the branchial arch fusion. Take care again. The cleft lip, unilateral isolated cleft lip, represent the failure of nasolabial ring fusion, no relation to the branchial arch fusion. Arch disorder have a far more profound phenotype and malformation sequence. Take care. Congenital hypertrophic pyloric stenosis is very common. It affects approximately about 1 in every 450 infant, so it's very common. It presents with vomiting after feeding. The baby will eat from here and vomit after that within minutes. It particularly liver be bile stained and usually projectile. The child will eventually become dehydrated and lose weight and might become fail to thrive. On examination, there is a classic olive pyloric tumor, olive mass-like in his chest. So again, the baby will eat and vomit. The vomit will be never bile stained and usually projectile. There will be olive mass in his chest. Take care, dearest great surgeon. Hirschsprung disease is usually present in the neonatal period with a history of delayed passage of meconium. The first thing come to your mind when any child comes to you in the very first day without passage of meconium, abdominal distension, and with or without bile vomiting, the infant might be shocked with impending even enterocolitis. The first thing come to your mind, Hirschsprung disease, and is very common with the children with Down syndrome or trisomy 21. Can be differentiated postnatally from the duodenal atresia, in which there is passage of meconium even in complete atresia. Take care. In MRCS, he might track you with timing. So when he tells you that there is an infant who was born preterm at 35 weeks of gestation, but then he mentioned that the child is very well for 6 weeks now, and asks you about this child have bile stain vomiting. So the incidence of necrotizing enterocolitis with bile stain vomiting only at 35 weeks of gestation, which is now 6 weeks beyond, and he is pretty well, there might be another manifestation to be necrotizing enterocolitis. So this might raise a midgut volvulus. Bile stain vomiting in previously well infant should raise the suspicion for midgut volvulus. But if he stated that the condition had occurred while he is still in early prematurity, so it will be necrotizing enterocolitis. Take care. Malrotation and volvulus usually present in the very first week of life, but may occur at any age. So take care. The vomiting is bile stain, and an urgent barium meal will diagnose the malrotation. If volvulus goes unrecognized, the entire midgut might become ischemic and gangrenous and require resection anastomosis. So a 1-week-old baby with profuse bilious vomiting and tender abdomen, there is no palpable mass. Think of midgut volvulus. Dear great surgeon, one told me why I have to know that a W might be in the hernia content in the sac. Because in the in the middle hernia, the W loop have to be inspected so you don't reduce the hernia content into the abdomen while inspection, while herniatomy or hernioplasty. You have to inspect the whole W loop because any part of this loop might be strangulated. If you entered and reduced this loop into the abdomen, you might miss the strangulation, or even it might be require resection, so you have to inspect it. Dear great surgeon, regarding the esophageal atresia again, it should be suspected antenatally in fetal stomach, is consistently empty on ultrasound scan. However, the presence of distal tracheoesophageal fistula usually allow enough amniotic fluid to be swallowed and reach the stomach. Typically, it's unable to pass a nasogastric tube beyond the second or third thoracic vertebrae body. Gas in the stomach indicates a distal tracheoesophageal fistula. This is a very crucial difference between the presence or absence of tracheoesophageal fistula with the esophageal atresia. For the general surgeons, you have to be aware of the rectal hernia. It's not a fancy hernia name. It might come in real life. You will find the patient coming to you with recurrent pain in his hernia side, and you find nothing like a small balloon below your fingertips, and it's amazingly reduced. But at some point, you will find the patient coming to you with the stabbing pain, it's the ischemia pain, and you are searching for the hernia. There is no true hernia you are searching for. It's just like a small balloon below your finger. Be aware it might be a rectal hernia. So this small defect, most probably come, I have faced two cases with umbilical hernia with rectal hernia. And no one believed me until we did exploration. It was at my junior residency. And the patient was amazingly what? Rectal hernia. Only the anti-mesenteric border was even almost strangulated. And we have to cut this loop. Thank God it was alien. So we did resection anastomosis. This great surgeon, one day you're gonna be a father or mother, and as a doctor you will be asked frequently for the alarming signs for children, or even to inspect the children for your friends. May God keep these alarming signs away from you and all of your beloved, but you have to keep it in mind because you can save lives. Take care. For example, the tracheoesophageal atresia, the esophageal atresia. It's a very common sign to be missed if there is no 4D ultrasound to detect it prenatally. Take care. The child in the very first few hours can't swallow his own saliva, and he will be filled with froth, with its saliva mixed with air. All his oronasal cavities, his nose and his mouth will be filled with salivation and frothy like. He will not able to swallow his own saliva and will die with aspiration. It can be solved right now with a simple procedure, multi-staging, but you have to detect it and keep it alarming. Just you are alarming the parent if the patient passes a stool or not, if he passed meconium in the first 24 hours or not, he is Hirschsprung or not. Take care. This great surgeon, take care. The normal man has two testicles in the scrotum separated by a median raphe. When we are talking about undescended testes, think, is it true undescended testes? Due to defect in the gubernaculum which grab the testicle in the scrotal cavity in its place, or it's just a retractile testis. The retractile testis, you will find the mother, and almost always the mother, because she takes care after the children more than the father by the humanity. Even it's a co-work, they have to look after the children together. But if the mother talked to you that one of the scrotum cavities is devoid of a swelling, which is devoid of the testicle. But she might notice it when the patient or the child is squatting. Tells you that she might sometimes feel the testicle while the baby is squatting. This is called a retractile testis and should be assessed after 6 months. So reassure the mother and reassess after 6 months. While if it's undescended testis, true undescended testis, where you can't feed the testicle in the scrotal cavity even with squatting, so you have to do laparoscopy and gain the testicle back to its place to prevent malignant malformation and give the patient a better chance to have children when grows up. And the hormones in the testicle is important for his puberty as well. A 4-year-old with solid right-sided mass. This is a Wilm tumor. The commonest renal tumor is nephroblastoma, which is the Wilm tumor. It presents most commonly from birth to 5-year-old. 10% are bilateral. Presentation is in 90% of the case with hard lateral abdominal mass, 10% of the cases with fever, poor appetite, loss of weight, and hematuria. Again, the commonest renal tumor is nephroblastoma, abdominal mass up to the age of 5-year-old. So a 4-year-old with solid right-sided mass might be a Wilm tumor.